Hi, I am Iskra Pusic, and I come from Washington University School of Medicine in St. Louis. I am oncologist, and I work in the field of transplant with a particular interest in graft-versus-host disease. So I am glad to talk to you today just a little bit about prevention and preemptive therapy for chronic GvHD. And if you attended some of the sessions during recent ASH and ASTCTs, there was a lot of talk about that. And I think this is really interesting and evolving field currently. So first, when we talk about prevention and preemptive therapy for chronic GvHD, even though we all often use those two terms interchangeably, there is a difference in a sense that prevention means really trying to prevent chronic GvHD from developing, while preemptive therapy is trying to act before more moderate or severe chronic GvHD happens and act earlier to stop further evolving of chronic GvHD towards more severe forms. And I think when we talk about chronic GvHD, it's important to say that this is a disease that is created by our treatments and something that occurs in people who are otherwise cured of their malignancies. And really over the last 10 years, there has been a remarkable progress in our understanding of biology of chronic GvHD and development of better mouse models, and a lot of effort towards further work on biomarkers that could play a significant role in trying to diagnose chronic GvHD early or identify patients who might require more intensive treatments. And there have been few efforts recently happening in chronic GvHD. One is a third NIH consensus conference, and one is State of Science Symposium, and both of those papers will be published very soon with new ideas, particularly concentrating about prevention and preemptive therapies for chronic GvHD and trying to identify patients who are at risk for developing more severe forms and then trying to find ways to intervene earlier on. And there have been several trials that are currently ongoing and awaiting results, trying different prophylactic regimens incorporated with conditioning, and to see what would be, which one will eventually prevail as standard of care to have better results on prevention of chronic GvHD. There has also been a lot of ideas and talk about use of post-transplant cyclophosphamide and ATG, and also developing a trial testing both of those interventions and compare which one would have eventually better results down the road on relapse and chronic GvHD. I also think it's important to underline when we talk about prevention of GvHD, another kind of competing risk is relapse and infections, and that it will be interesting and important to try and test agents that could also potentially, aside from working on prevention of chronic GvHD, have an effect of reducing relapse down the line and in that way improve the outcome of these patients. So as I mentioned, there is currently in final stages of development papers from the third NIH consensus conference. And there has been a lot of discussion and primarily new ideas on further refining the ways how we act for prevention and preemptive therapy for chronic GvHD. And the idea is really to have a drug to intervene earlier in the development of chronic GvHD as on one side, and also treatment of early newly diagnosed chronic GvHD. And these patients are much more homogeneous group, and then trying to use drugs, new drugs without steroids as single agents. And by acting on newly diagnosed early chronic GvHD, we could really work preemptively to prevent more moderate and more severe chronic GvHD from happening down the road. And I think that it's really exciting time to be working in the field, and there are a lot of new drugs that are now available, and some of them even developed particularly for chronic GvHD. And even though we have a drug that's now approved for steroid refractory chronic GvHD, and many of these drugs are initially tested for steroid refractory chronic GvHD, I think time has come to really start using these drugs earlier for newly diagnosed chronic GvHD, and then design trials really testing them in prevention of chronic GvHD. And it's really going to be interesting to design these trials and refine inclusion criteria, because you, again, don't want to put these people at risk of relapsing. So it will require a lot of fine-tuning in designing trial and testing these drugs.